Good afternoon, everyone. Thank you all for joining us this afternoon. My name is John Rodis. I'll be moderating today's session of the Moving to Value Alliance's webinar entitled The Role of the Primary Care Provider in Disease Prevention and Management in a Value-Based World. For those of you not familiar with the Moving to Value Alliance, our mission statement is here. Basically, our purpose is to support a value-based healthcare ecosystem with the highest quality health outcomes at a reasonable cost for plan sponsors and their members, beneficiaries, or employees. For those of you who are not members, I would urge you all to join. It's free. If you just go to movingtovalue.org, you can sign up. And everyone who participates today and is also signed up will have access to our entire webinar, both the audio presentation as well as all of the slides we're going to be presenting. So again, I urge you to join our group. Once again, no cost. We're joined today by Jeff Hogan, who's one of the founders of the Moving to Value Alliance, who's been in healthcare actually almost as long as me on the broker and benefits management side of the equation. He'll be fielding our questions and triaging them accordingly to the right speaker. Each of our speakers today will spend a minute or two introducing themselves and then get into their topic. So I'm John Rodis. I'm an obstetrician by training. I spent 20 years in academic medicine at the University of Connecticut, taking care of high-risk patients, teaching residents and medical students, publishing papers. And after about 20 years, I got recruited down to Stamford Hospital in Fairfield County as the chief medical officer. And in that role, I oversaw patient care quality, safety, patient experience, patient satisfaction, and risk management. I learned a lot about those spaces over that 8-year period of time. And frankly, I loved it there, but I was commuting 150 miles a day. So I was thrilled to get an opportunity to come back to the Hartford area where I lived, to St. Francis Hospital, 600-bed hospital in New England, the largest Catholic hospital in New England, where I came back as chairman. But then 2 years later, I became the chief operating officer and executive vice president. And during that time, I really took what I learned at Stanford and helped St. Francis raise the bar for quality, patient experience, patient satisfaction. And they were already pretty good, but they even got better, and they were already a low-cost provider. Interestingly, I then became the president in 2015 and did that for 5 years. And, you know, I was frustrated, to be honest with you, that here we had a hospital that was highly rated by any possible metric you can come up with, whether it's IBM Watson's top 100 list, Newsweek's top 1,000 list, 8 A's in a row from Leapfrog for Patient Safety, and I knew we were a low-cost provider. I was frustrated that business wasn't just pouring into us. Around the time I was getting my MBA, and I couldn't think of another business that if you provided a good product with a good service at a low cost, your business would grow. Healthcare seems to be the exception to that rule. And that really drove me to join the Moving to Value Alliance, founded by Paul Grady, Steve Schutzer, Jeff Hogan, and Christine Arnold. And I'm a proud member of that group today. So what's the problem? Well, the problem is we spend about $4 trillion on healthcare, and how it's spent is very interesting. And you've probably seen slides like this before. About 6% of the population is where we spend 60% of the total spend. It's kind of insane. That top group, though, and this was published a couple of years ago by the Hartford Business Journal, that top group really falls into 3 tranches of groups. It's a somewhat heterogeneous group. One group are the folks who have a one-time catastrophic event. It's the roofer who falls off the roof and breaks his neck, the motorcycle accident, the mom who has premature twins at 24 weeks, things that I used to take care of, or the baby that has congenital heart disease that's going to have 3 heart operations in the first year of life. Those are those one-time catastrophic events that probably can't do much about. Then there's a group at the other extreme of life that are really going to die sometime in the next few months. They're going to die of usually end-stage renal disease, end-stage lung disease, end-stage heart disease. And that group probably doesn't need to come to a hospital. They really should be managed better with advanced directives and hospice care and not consume a lot of money that is spent. People used to ask me, why do you spend so much money on people the last 30 days of life? And my retort was often, if I knew it was the last 30 days of their life, I might not have spent the money. We don't always know that, and we're obligated once patients are in there to do the best we can, but it's very costly. But then there's another group, the third group that Bill Bestermann is going to talk about today. Those are the patients who have chronic conditions and end organ damage But truthfully, if managed better with so-called optimal medical therapy, you could reduce hospitalizations and keep those people healthier, keep them out of the hospital, and let them live longer and with better lives. The bottom of this pyramid were the healthy folks. I would argue those are the goal of screening and prevention. When I give this talk to medical students, I say their goal in life is to keep people in that cohort. That's the group that we spend very little money on, and they're healthy. The group in the middle, and I think Kenny Cole and Garry Welch are going to address this group in particular, those are people now who have diabetes, have hypertension, and we want to keep them in that group or drop them back into the healthy group and not have them rise up to that advanced illness disease, because most of that people at the top in that cohort that I alluded to can be prevented. When you look at this differently, again, the left side shows that the top 6% or so, top 5% consume almost half or more of the total dollars. Actually, the top 1% alone account for 20% of the total spend. But look at the right side of this graph. The bottom half people, we only spend 3% of the total healthcare dollars on. I would argue we should probably spend a little more on them and a little less on the people at the other end of the curve. You know, America, we on a per capita basis, we pay about twice as much for healthcare on average of other developed nations. And we don't have a lot to show for it. We're not in the top 10 in almost any category of quality of health compared to other developed nations. You know, it's even worse than this, actually. When you look at these, if you multiply these numbers by the actual population, again, these are per capita figures, what you'll find is that the United States, which only has 4% of the world's population, consumes 50% of the total healthcare dollars. We spend 50% of the global healthcare spend in our country, even though we only have 4% of the population. Where's the money spent? Well, $1.2 trillion is spent in hospitals. That clearly hospitals are an obvious target. A lot of folks are working in that. And for those employers in the room, you can save a lot of money by shopping for less expensive care that actually is going to be as good or even better in quality. The folks at 32BJ in New York have shown this. They have 170,000 union members. They've been able to eliminate premiums, eliminate deductibles, and actually give bonuses to their union members. You can shop better. There's no reason why you have to pay twice as much for colonoscopy, twice or three times as much for hip and knee replacement. There is tremendous variability in this. I'd urge you all to read the RAND report 4.0 came out this year. There's variability in price and quality between states, within the same health system, in the same state. And you should take advantage of that variability. It costs about $8,000 to have a baby in Arkansas and $25,000 to have a baby in San Francisco. I've delivered babies in 10 different hospitals. I'm telling you, it doesn't cost anything different. So the difference is the price you're all willing to pay. So, but I think the better thing to do, rather than just negotiate better prices, is reduce the hospitalization in the first place. That's the best way to save money, just don't spend it. And you could reduce a lot of hospitalizations with better care. Interestingly, also, you can see that about 14% of money is spent in physician services. Only about 5% of the total $4 trillion spend is spent on primary care. Again, I would suggest, and hopefully you'll agree, that more should be spent in that space to prevent some of these hospitalizations and chronic conditions. And then finally, prescription drugs, you notice, take up a nice chunk, that green slice of the pie. There's a huge opportunity to save money. I know that state of Connecticut, with Tom Woodruff's work, has done work on really getting access to this information from their third-party administrator and really been able to negotiate and reduce the price they pay for drugs. There's lots of opportunities there as well. Why are these people hospitalized? Well, these are the top 10 causes of hospitalization in the United States in a non-COVID year. All these slides pertain to non-COVID years, the last few years. COVID, of course, is now the third leading cause of death for the last 3 years. But on a non-COVID year, these are the common cause of hospitalization. This excludes maternity. There's about 3.5 million births in this country every year, and pregnant women are often hospitalized more than once during a pregnancy. So there's a huge opportunity there. And that goes back to my earlier comment about negotiating better prices. You should not pay twice or three times as much to have a baby and newborn. The state of Connecticut's working on bundling that maternal child package. You shouldn't be paying that much more for cesarean versus vaginal delivery. Again, huge opportunities to save money here. But if you look at this list, a lot of these things on this list are preventable, modifiable, delayable. And as a matter of fact, look at the next slide. You'll see they correlate very closely with the top 10 causes of death in this country. So this is the top 10 causes of death, and this list is, well, changes every few years. Diabetes is moving up the list pretty steadily, as is Alzheimer's, but the top two, heart disease and cancer, which account for 50% of all deaths, have been leading this graph for a long way. But as you can see, not only are most of these things preventable, a lot of them were on the list of causes of hospitalization. Those top 10 account for 3/4 of all deaths. Again, heart disease and cancer, about half. All but one of them are preventable, treatable, curable, or at the worst, delayable, modifiable. Ben Franklin said almost 300 years ago, an ounce of prevention is worth a pound of cure. He was talking about fires, by the way. But truthfully, if we haven't just talked about creating a burning platform, I don't know what I failed as a speaker. So can we prevent a lot of disease? Well, the answer simply is yes. Heart disease largely can be prevented. Don't believe me, I'm an obstetrician. The American Heart Association says about up to 80% of heart disease can be prevented with a healthy diet, exercise, not smoking, avoiding obesity and diabetes. And if you get diabetes and hypertension, they need to be managed better. We do not do a good job in this country on this. Hypertensive, as an example, about 44% of people with high blood pressure under the care of a doctor have normal blood pressure, which means 56%, more than half of people with high blood pressure, do not have normal blood pressure. There's a thing called therapeutic inertia, where doctors aren't even increasing the dose of medications, even in the face of continuing hypertension, or they don't add a second drug. We need to do better, and we're going to hear more about how people do that. Diabetes, the picture is even worse. Only about 20% of diabetics have normal blood sugars. Again, these are diabetics under the care of providers. And by the way, nothing I'm saying is new. Everything about the prevention has been known for 25 or 30 years or more, but it hasn't been adopted readily. People know, everybody knows you should take a statin to reduce your chance of heart attacks if you're in a high-risk group. But truthfully, look at the impact of stopping smoking or a healthy diet and exercise as risk reduction. Far more effective and less costly. As a matter of fact, you could save money by smoking cessation. Lung cancer, 80 to 90% of lung cancer. Lung cancer is the leading cause of cancer death in men and women in this country. It has been for a long time. When I was in school, lung cancer was not on the list of leading cause of death for women. But remember the old ad, "You've come a long way, baby," that Virginia Slims did? Well, indeed, women have. And it's the leading cause of death for them from cancer. 80 to 90% of lung cancer is linked to cigarette smoking. 80 to 90%. 80 to 90% of COPD, which is also on the list for hospitalization, is linked to cigarette smoking. Colorectal cancer, which is the second leading cause of cancer death for men and women, is really a Western disease. In countries that live on predominantly a plant-based diet with, high fiber diets, plants, vegetables, legumes, fruits, have very low incidence of colorectal cancer. So not only can it be prevented, with screening colonoscopies, at least, we identify precancerous lesions. This is an important point on the population health and the social disparities of healthcare. Lower income populations, those who have limited access, tend to have a lower frequency of colonoscopies. We can do a better job there. Now, I didn't learn any of this in medical school because we weren't taught about prevention. We're taught diagnosis and treatment. We're really not taught about prevention. We're also not taught about the continuum of disease, how people, you start being healthy, and then you get a little heavy, you get a little diabetes, you get a little hypertension, and then you have a stroke. That's kind of how it happens, but that's not the way really we're taught. We're taught to diagnose and treat. But this is just from Harvard just a couple of years ago. General cancer prevention recommendations. You could all find these yourself. Again, you're going to see a lot of redundancy here about diet and exercise and limiting alcohol. And it's all the same over and over again, staying lean. I'll do a shout out here for sleep. Sleep is really, really important. I would urge everybody to read the book, Why We Sleep, by, I think Matthew Wallace wrote it about 5 years ago or so. It's a great book. And you should get 7 to 9 hours sleep a night, and I'll leave it at that. Some people say, "Oh, it's in genes, nothing I can do about it." Well, Dean Ornish showed this many years ago and I did a genetics fellowship years after my other fellowship in high-risk OB, and genes are not all active at any one time. Actually, only a small percentage are active in your cells at any one time, and genes are turned on and off all the time. And what Dean Ornish showed, this was in a group of men with prostate cancer, what he showed is that with a combination of a healthy diet, exercise, and some meditation practices, you could turn on the good genes, those that are tumor suppressor type genes, and you could turn off the proto-oncogenes, the ones that promote cancer and growth of tumors. Again, nothing new here. It's been known for a long time. What about diabetes? Well, when I was in school, diabetes was 50-50, type 1 and type 2. Today, more than 90% of diabetics are type 2 in America. There's 37 million adults with diabetes, 1 out of 5 of whom have not been diagnosed. There's 96 million other folks that have prediabetes. If you look at the math, about 5 to 10% of them will convert to diabetes every year. Figures range from anywhere from 70 to 90% of those folks will become diabetics in the ensuing decade or so. And then if you follow them for another decade or so, a lot of them will have eye disease, retina disease, kidney disease, nerve disease, or heart disease. If you look at it from a dollar point of view, diabetes counts for 1/4 of the total dollars spent in healthcare. It's a staggering figure. We're talking about $1 trillion. And you'll hardly ever hear a doctor say what I'm going to say, but virtually 100% of type 2 diabetes can be prevented. Not treated, not managed, just plain old prevented. Weight is a big factor here, especially that visceral fat that people talk about, that central obesity. The chance of getting diabetes if your BMI is under 25 is very small and almost zero if it's under 23. Healthy eating, we're not talking about diet and weight necessarily here. It's about healthy eating, but obviously healthy eating will lead to less obesity. What about stroke? According to the American Stroke Association, up to 80% of strokes can be prevented. 80%. My dad had a stroke in his early 80s. He never wanted to be hospitalized with a stroke. He made that clear to me when I was younger. Well, he got a little heavy in his late 60s, got a little hypertensive and a little diabetes in his 70s, had a massive stroke in his 80s. That's how it happens. Again, you can prevent them by the things on this list. Kidney disease, it's hard to find a figure, but I would estimate at least 3/4, if not 90% of kidney disease can be prevented. I'm sure Bill and Kenny could address this issue. How do you prevent it? Well, just prevent diabetes, prevent hypertension in the first place, but just manage them better when you get them. Interestingly, and this is striking, really, 9 out of 10 people with chronic kidney disease don't even know they have it. 2 out of 5 people with severe kidney disease, these are folks who are on the road to dialysis, don't even know they have it. And for those non-physicians in the audience, this is not really that hard. It's a kind of a simple blood test to do an estimated glomerular filtration rate or measure the amount of microalbumin, protein that's in the urine. It's not done common. President Biden last week had a summit, the first time in 50 years, a summit on health and nutrition. And, even though I ran a Catholic hospital, admittedly, I do believe in evolution. And this is humans, Homo sapiens have only been on the planet for about 200,000 years. But look what's happened in the last 50 years. Why is really because of what we're eating. And literally, we're eating ourselves to death. So obesity has become an epidemic. We have ready access to fast food, which is high fructose corn syrup, high salt, high refined flours, and processed meats. And we also have a sedentary lifestyle. When I was a kid, if you took a combination meal at a fast food restaurant, it was about 400 calories. A similar meal today, and we're not talking a supersized meal, just a similar meal today is 1,400 calories. And this is very high amount of sodium, very high amount of high fructose corn syrup, very high amount of refined flour, and also a lot of saturated fat. So the result of all this, if you look in 1990s on the top of this, I don't expect you all necessarily to read it, but basically the left column is obesity. The right column is severe obesity, BMIs over 35, which wasn't really that much of an issue in 1990, as you could see. But as you work your way down to what's going to projected for 2030, even states like Colorado that have been somewhat immune from this for a long time have obesity. So for those of you who think this is just like a Southeast United States problem, it's not. It's a national problem. Actually, it's becoming a global problem as we have westernized the diets of the rest of the world. Listen, I know change is hard. I've adopted a lot of these principles myself, where I don't want to be hypocritical. Garry Welch introduced me to the American College of Lifestyle Medicine, and I became board certified in it last year. And I learned a lot about change behavior, a science that didn't exist actually when I was in school. There's 2 Nobel Prizes in the last decade for this. You can do it. People can change behavior. Physicians need to recognize where people are in their journey and help them and nudge them to move in the right direction. So thank you for your attention this afternoon. I'm going to now pass the baton on to Kenny Cole. Kenny's the System Vice President for Clinical Improvement at Ochsner Health System. And Kenny, tell us how you at Ochsner handle this dilemma that I've just articulated, and how you incentivize your docs to do a better job. Thank you.
Thanks, John. Appreciate it. And my title may sound really vague, but one of the things that I would posit is that the only way we're going to get to the types of outcomes that are going to generate the results that John and the others on this webinar will be speaking about is we have to focus on improving outcomes, and that's going to involve transitioning primary care towards what I would call next generation primary care. And so next generation primary care, or advanced primary care, it is really where I see sort of the future of healthcare moving. And the only thing that's going to enable this to happen, quite frankly, is business model innovation or business model reinvention. And we're going to have to move it away from transaction-based, fee-for-service, volume-driven reimbursement or financing mechanisms and more towards population-based payments. And that's either going to have to come through the commercial payers, or it's going to have to come directly from employers. And so this is really an image that I can relate to all too well. And I think most primary care physicians can relate to all too well. I mean, you're seeing 20, 25, 30 people a day. You have, 10 or 15 minute visits. And it's literally just impossible to be able to meet all of the demands, address all of the concerns, answer all of the questions within the context of those short visits, especially for the more complex patients where a lot of the excess medical expenditures and complications lie. And what this has created is this model of sort of hamster healthcare, where providers, especially primary care physicians, are just running faster and faster to stay in place. And what we're seeing associated with that are epidemic rates of provider burnout. We have as many as 46% of primary care physicians reporting burnout. We have 50% of primary care physicians reporting that they want to leave practice within the next 10 years. And 70% of them would say they would not recommend a primary care to a loved one. We have to change the fundamental economic model in order to change the delivery model. So here's the thing: not enough hours in the day describes primary care all too well, right? So Osby and Yornow discovered this over a decade ago, where they found that for a typical panel of about 2,500 patients, to adequately manage the proportion of patients with chronic conditions on that panel would take about 10.6 hours per day. And then for that same panel to proactively address all the preventive care and health maintenance of those same panel would take another 7.4 hours per day. So let's do the math, and we're now at 18 hours a day before you've even seen the first sick patient. And so is it any wonder that we're seeing misdiagnosis in as much as 15% of patients, and that in turn is accounting for an additional 17% of adverse events and unnecessary cost? And is it any wonder that we're seeing issues with access and cost, quality, and patient experience in the traditional primary care model? And to add to this, just this year, the Journal of General Internal Medicine published a study where they used analytical modeling to determine the number of hours per day that it would take a primary care physician to address all the needs of a panel of 2,500 patients. And the answer came back 26.7 hours per day. But if you changed and you implemented a team-based approach to primary care, you could shrink that down to about 9.3 hours per day for the same size panel. And so when John mentioned earlier about the enormous amount of money that's going towards the hospitals, towards specialty care, towards procedurally oriented care, we're spending way more money, unfortunately, on the stents and the bypass surgeries and things like that than we are up front in terms of how do we really, really spend more wisely on primary care to achieve better outcomes? How do we move the current economic model's focus on downstream solutions and what we're doing in terms of just this reactive approach to the complications, instead of coming well upstream into proactive solutions? Right now, we're spending 5% of the healthcare dollar on primary care. If we could probably double that, spend 10% on primary care, and we would yield 20, 25% or more reductions in total cost of care. And so enabling primary care to deliver the type of value that it's capable of generating by allowing this facilitation to advance primary care. So this was a slide that I created, probably about 5 years ago, when the CEO at the time at the health system where I was at the time he said, you've got 10 minutes and one slide to tell the board, what do you see as the future of healthcare? And so this is what I came up with. And I drew on the left an inverted pyramid where primary care is really their primary role is as an acute care feeder to the higher margin revenue generating service lines of business, the procedurally oriented specialists, the surgical care, the hospitals themselves. And when you have a financial model that's built on fee-for-service, volume-driven transactions, the business model is really about the market power that hospitals and health systems can leverage over the commercial payers to drive rate increases that then enable them to invest in the capital-intensive, cath labs, operating room suites, hospitals, and so forth. And you end up with this vicious circle of care that's based entirely on the economies of scale, where it's really about how much stuff do you sell? Essentially, that's the strategic question. The central strategic question is how many more surgeries can I do? How many more procedures can I do? And when that scale becomes, that model becomes untenable, right, and financially unsustainable, you begin to sort of transition over into like maybe some pay for performance type stuff or some shared savings where you go into contracts where it's like, look, how about if we do a better job of delivering care, then maybe we can split some of the savings that we create, right? You sort of move into that. But those are incremental transitions of the delivery model that aren't what I'm talking about when I talk about advanced primary care. When you talk about advanced primary care, it's essentially you're inverting this pyramid completely. Primary care is no longer an acute care feeder. They are the foundation of your entire delivery model. They become an enhanced customer acquisition channel where they grow the number of lives that are attributable to the system. Yes, you'll still need specialists, and yes, you'll still need hospitals, but you decrease the need for both of them as your economic model has changed through a model of risk-adjusted capitation and population-based payment. And the emphasis becomes on the value that you can create for your customers. And so what does this new primary care model look like? This is sort of what we can depict that upside, the right side up triangle can look like, right? It's going to mean a different operating model. It's going to mean different operating metrics, different performance metrics. What it primarily means, first and foremost, is that the emphasis is entirely on the creation of health. And then doing that is understanding that health is multidimensional. Health is more than just the absence of infirmity or disease. It's the complete state of social, mental, emotional, physical, and functional well-being. And what it does is it begins to look at the social and economic factors of healthcare as being some of the barriers and the obstacles and the challenges to a person achieving their optimal state of health. And then what becomes reflected is the clinical care model has to shift in order to help overcome those barriers. And so you start changing your performance of how you measure how you're delivering care. You're no longer measuring things like RVUs and volume of visits generated. You're measuring how deeply is your care team engaged when they come to work every day to connect with the deep sense of purpose of why they entered healthcare. You're measuring your net promoter score and placing a huge emphasis on how likely would you recommend this type of care to someone else. You're focusing, instead of RVUs, you're actually focusing on how few ER visits, how low can I drive those ER visits down, or those admissions down, or my readmission rate down? How can I create value for an employer by reducing the number of unscheduled days absence from work and improving employee engagement because people feel mentally and physically healthier to come to work? And then lastly, how can I favorably impact the health plan PMPM trend to reduce their medical expenditures to create value for them? It takes a very different operating model. It takes one that absolutely is going to be composed of team-based care, where provider leadership is key. Proactive care management is embedded as a member of the care team. Fully integrated behavioral health, because mental health should never be divorced from physical health. And so an LCSW would be an incremental part of this model. Embedded nutritional support counseling, health coaching, and then especially for employers, an integrated musculoskeletal solution. Because if you nail all of that correctly, better health does indeed equal reduced health plan medical expenditures. When we look at a Venn diagram of traditional versus advanced primary care, you can see on the left is the traditional model. It's a one-size-fits-all approach. You get the same 10 or 15-minute visit to see an 18-year-old coming in with a sore throat who's not taking any medications and who's healthy as can be, as you get same 15-minute visit to see an 85-year-old who's on a dozen medications with multiple medical problems, who's there for polychronic condition management. And the team is the same, right? It's all about this reactive downstream approach where it's a transactional model. The fundamental question is how many visits per day, how many RVUs are generated, and the team is going to be ratcheted down to the absolute lowest number of resources you can possibly have. Primary care doc, a medical assistant, maybe 2 medical assistants at the most. The key metrics of success are going to be, volume and RVUs generated. Patient experience and provider engagement become output metrics, right? They're a result of the design of the care model. They're not carefully curated as a discrete metric. And if you can click through a couple times, Karen, just to get through the animation. Thank you. The advanced care team, primary care, uses a risk stratified approach. You do longer visits for the more complex and challenging patients. You do shorter visits and virtual visits for the young, healthier people, right? You start to diversify how you deliver care by aligning the skill, the task, and the resources to those who require most. So much longer visits for the much higher risk patients. Everything, the whole focus is now on proactive and upstream. And it's not transactional, it's relational, because transactions don't heal people, relationships do. And the care model is all about the team. And the metrics of success are no longer volume, but the dollars saved, and patient experience and provider engagement are the input metrics. And so then the next slide, this just depicts, on the next slide, it really depicts the idea of what are the true drivers of health outcomes. Because you see, clinical care is only accountable for about 20% of health outcomes under transaction-based financing. The social and economic factors account for 40%, health behaviors account for 30%, and the environmental factors are about 10%. And unfortunately, one of the dictums in healthcare that exists currently is this notion of patient compliance, right? A standard model would look at this and say, yeah, how can you expect me to alter health behaviors? I can't control the social and economic factors. I can't, change a patient's behavior. Their view is one of their role is telling a patient what to do and expecting or demanding patient compliance. I would challenge that by saying it's not the patient's job to do what we tell them to do. It's our job to earn their trust and go on a journey with them where we help them to achieve the health goals that matter most to them. And when you structure it that way, you can indeed change health behaviors and you can drive tremendous improvement in health outcomes. And so when you're looking at what this looks like, and it's football season, and so I think this is sort of a good example of sort of bringing it all together. And so let's think of it as like this drive towards health improvement. And what are the barriers that stand in the way of a patient towards achieving their health-related goals? In this example, the care team, the advanced primary care team, is the offense, and the patient has the ball. And the would-be tacklers, the progress that we have to make against that defense to help us get to those health goals, are all of the things outlined in red. It's the polychronic nature of multiple overlapping chronic diseases. It's the person who's got diabetes, hypertension, obesity, chronic kidney disease, often coexisting with anxiety, depression. And I can tell you in the care models that we're doing, nothing less than 90+% rates of hypertension and diabetes control are acceptable in this advanced primary care, and they are indeed achievable. And that's when you understand that the reason why those health behaviors are driven the way they are in many cases is some of these patients have adverse childhood trauma. They have impaired mental health through no fault of their own. They've adopted maladaptive coping mechanisms and unhealthy behaviors, and they have impaired social determinants that act as the barriers. And so the idea here is to curate, carefully design the team where the physician becomes a coach and you help this patient achieve against these barriers. It does work, it can work, and the only thing standing in the way of this becoming the way advanced primary care or the way primary care is for the entire country is the economic model has to change. Once it changes, the whole basis of competition is going to be to compete on the outcomes that we can generate rather than the volume of care delivered. Thank you.
Thank you for a great explanation. I love the idea of the coach as a team, the physician as a coach of the team. We're going to pass it over now to Garry Welch, the founder and chief scientific officer of Fern Healthcare. Garry, it sounds like Fern would be an important part of the team that you're just talking about. Tell us about Fern, please.
Hi, John. Thanks for that handover, and it was wonderful to hear that walkthrough of the advanced primary care. What I'd like to talk about, I'm a research psychologist who's been very interested in the patient's journey of living with chronic conditions. What are the self-management things that they have to do? What are the psychosocial issues? What are the social determinants? How do we get that from the patient, that story, and get it into the treatment plan and get it into the team members in a way that's efficient, that unlocks really the journey the patient's going to be on, and who's going to join the patient on that journey. So with Dr. Cole's set up here, what I'm talking about is a specific tool that's very strongly digital, and it's a way it gets that job done. It reaches out to the patient and pulls that data into the treatment plan, into the care team. So what I want to talk about is the patients. It's they're on a journey, chronic conditions that we've covered, all these hypertension, all these hugely impactful diabetes, chronic kidney disease. The journey the patient's on is a lifelong one. So who's going with them to help them? And if it's the employer that's with the employee for a long time, that's a great fit. But a lot of our system is designed for short-term interactions or staying with the patient for a short time. So we're really looking at the long view here. So I agree totally with Dr. Cole and with the whole sort of approach of the value-based model. So what I'm talking about today is a decision support tool set for primary care, advanced primary care teams. And it's for the extended care delivery group. And what I've done is develop this digital tool set. I've tested it. It works in community health centers, in NIH-funded research, and it's worked in primary care clinics and diabetes clinics. And what I've done as a co-founder of Fern, with my co-founder and the business people and others that I've joined, is how can we get this tool set out into the marketplace? And so what we want to do is unlock this patient's story, get that data into the treatment plan, and help give the clinical team this extra data so they can act on it and really develop this relationship with the patient over time and solve for all the problems and issues and preferences that the patient has. So what we're trying to do is improve the efficiency of clinicians, have a very standardized approach for unlocking the self-management behaviors and psychosocial, and also improve the trust, as Ken said. And we also can use this digital outreach, and I'll talk about some examples of implementations to reach people that usually don't get to the clinic or find it hard to get their self-management and psychosocial story told. So what we're talking about is a tool set. It's a digital tool set, pops up in the workflow. It's integrated through APIs, etc. And what we're doing is we have different programs. Some of them are these. They're really basically three things. It's an assessment. It is short, sharp question sets that take a couple of minutes to complete. And they can be completed by either a text assessment, email, in person, over the phone, with the patient in their home. A lot of ways we can get that data depending on the needs of the patient. And what we do is we pick up these little bites of information through these channels, omni channels, and then we provide the clinicians with flagging and patterns. And we provide them clinical suggested actions to support them right down to each question. What would be a good way to cover off on each thing flagged for a given patient? And then we roll it up to decision, sort of tableaus, what we use for data visualization, but we can roll it up to population insights, which gets really interesting. And the programs that we have to support clinicians, type 2 diabetes, heart failure, hypertension, which covers a lot of things that John introduced. We also have specific ones for pre-diabetes, where patients can, as John mentioned, can end up with 2.3 times the cost, and also healthy lifestyle and disease prevention. So we have solutions at that end too. But what I want to talk about today is just type diabetes, to have an example. So on the right-hand side is showing a schematic of these bite-sized assessments that go out to the patient or completed with them, and they're in what we call modules. And so on the inside, we've got 6 modules that are the most important self-management behaviors for type 2 diabetes. And that we have at the top, the fork and the knife is a meal plan. The second is physical activity, medication taking, blood glucose monitoring and CGM, smoking cessation, and the typical screenings that patients need to get with type 2, which are tied to NCQA. And that is really the set of things that patients have to figure out how to do. And what the questions try to get at is, and there's the down to Medicaid reading level, is what are you doing? What would you like to work on? And where are you getting stuck from common barriers we know from seeing a lot of patients? So we unlock these and we give them up to the clinician when they're ready to see the patient in whatever way. And on the outside, you see these psychosocial barriers, and we've alluded it in some of the presentations just before, but there are a lot of things that get in the way. It could be health literacy and numeracy, it could be social determinants, it could be mental health issues, it could be poor sleep, it could be patients have a treatment-related emotional burden, they're just getting burnt out and disengaged. So these, again, we screen briefly and unlock, solve for that for patients. We get that into the treatment plan. And you might think, well, this is a lot of stuff, but this is the long journey. And we go at the pace of the patient. We go at whatever the clinical team thinks is a good cadence. And we repeat these over time, and it's a long journey. And we start to work with the patient to build up trust and unlock things that are important to them. So here's an example, and then I'll go to rolling up the data into evidence and how to use this at a population level. But just to make it more concrete, here's Joe. He's works on a building site. He's got type 2 diabetes. He's taking a lot of basal insulin, but he needs to start using an insulin pen with meals to kind of really start to get his blood glucose control. And so he's being seen in this program. We start to send a couple of modules out to Joe, and we figure out that he's actually completely burnt out with his diabetes and he's disengaging. But we find also that he's having a lot of problems with the insulin transition. He works in a building site, he's worried about low sugars, he's worried about people seeing him with a pen, don't know if he can afford it, is it on his health plan. So we also unlock about some things about physical activity, sexual functioning, and his blood sugar monitoring and using that data in a smart way. So in a few modules, we quickly unlock things that are really important for Joe. We get that into the treatment plan. And if we actually respond and help him, we can get some real traction and engagement. So on the right-hand side, you see the kind of the cadence of the assessments. There are foundational ones we can do, but we can screen initially for social determinants, behavioral health, treatment, burnout, and health literacy. Maybe we start with some of those, and then we move to self-management issues and other psychosocial issues. So we've got a kind of a strategy for the healthcare team to think about every Joe that they see. So when you look at Joe, what does he get before we go to rolling this data up to a higher level? He's getting maybe into a diabetes educator quickly, one who's really more hardwired into the local advanced primary care group. He may get help with sexual functioning from the primary care team. His A1C improves. We manage hyperglycemia for him particularly, and that's doable because we know that's important for Joe. And we lower his diabetes distress, which is related to the burnout of the self-management. And so we can actually help Joe feel better, and the team is pleased also with the progress. And we can measure his progress of diabetes emotional distress pre-post. So just start looking at two things here. One, on the left-hand side, there's a whole body of clinical research that I led with 30, 50 clinicians and researchers that were part of a sequence of studies, or 9 of them were NIH funded, community health center based, and diabetes clinics and primary care end of the healthcare system. So we did a lot of studies to prove that this tool set worked in busy clinical settings with multilingual, bicultural kind of teams. And what we do now on the right-hand side, we're starting to implement this in real-world commercial settings where there is care delivery for primary care. Just teasing out a few more implementations so you get a sense of, whether this works in the real world. Diabetes, emotional distress of enrolled employees. This digital outreach to get this data from the patients, sending out text and email messages to patients, and unlocking and blood sugar monitoring, and also poor sleep. We screen for those very efficiently. So this is a very efficient way of getting this data and also unlocking new data that the team hadn't seen. And down below, in terms of home health, we use the same text and email asynchronous sort of assessments going out to the patient using these personalized URLs, which are very secure. And when you look at NCQA, the modules that we have, they map onto and they support these quality improvements if these modules are used. For example, in a federally qualified healthcare center we worked with for A1C control, as one of the diabetes metrics, we're able to double the percentage of patients with A1Cs below 8%. So this kind of, we're supporting HEDIS quality as well at that level. And then you roll the data up. You start to get insights of the population or specific populations. So you can see, you can think about it in terms of modifying the programs you have, changing benefit design, predictive modeling, and it's a real way of seeing the real-time onboarding of patients and what modules the clinicians use, but also starting to look at the results of populations. So here's just a very type 2 diabetes, looking at the behavioral health module and the coping styles module that Ken mentioned before, that coping styles are important to understand, as well as mental health issues. For example, here we have on the top left the PHQ-9, which is a standard depression screening. We can provide for a population the specific levels of depression in a population. We can provide the emotional burden of diabetes for a population where the flaggings occur. And on the top right, we see GAD-7 is the generalized anxiety, and below is the coping. So we're starting to unlock, and we go on this journey of exploring this data, and the advanced care groups can pull this data into their data lake and really use it for their analyses to improve the way they develop programs, and also informs benefit design. And just to give you like a granular example of how this can be helpful, both in benefit design and program design, you can see here all these very specific barriers that are very common in for people with type 2 diabetes when they're trying to monitor their blood sugars. And if you look at the uncoached group, they have much higher levels of problems with these barriers. If you also look at the issue is that it gives you, for a population, where to direct your energy. So all the way across, and this is the same for medication taking and other areas, we can unlock barriers at the population level that inform both about insurance design, benefit design, and also care programs. So just to wrap up here, just to be clear, we are a tool set that goes into the workflows of care management teams that are managing chronic diseases and pre-diseases. We're on the left-hand side, along with all the other medical tests and screenings that are in the toolkit of advanced primary care groups. In the middle is care management and digital health companies, and on the right is the patient. So tying in with Dr. Cole's way of looking at it, which is we're exactly aligned with that. The new post-COVID primary care model is the MD is the quarterback. On the right here, we see the providers, including the MD, are doing telehealth visits. On the right-hand side, we have this extended chronic care team, which is now it's virtual, it's different business arrangements. It can be in person, it can be in the home, it can be all sorts of chat and calls, and different ways in which we can leverage the expertise here so that each of those works to the top of their license. And from the kind of tool I'm talking about today, they get the information they need. And on the right hand and bottom right, we're seeing that we have a whole wealth of valuable information we can collect efficiently. It's remote home monitoring, it's wellness apps, it's the kind of the information that we unlock today. And we bring that all together to create this journey with the patient. And this kind of tool that I described today, it can be used for IDNs such as Kaiser. It can be used in a lot of different digital and home health contexts. So that's really the tool set we're looking at to get out in the marketplace. But it's definitely, advanced primary care is a great place for it to be. Thanks, John.
Thank you. Thank you so much, Gary. Much appreciated. And now I'm going to pass the baton over to Bill Bestermann, who's an internist by training, who's been practicing what I was preaching about, preventative cardiology, for more than 20 years. Bill's a senior clinical advisor at Congruity Health. Bill, take it from here.
Well, in order to do this right, you've really got to bring together a comprehensive solutions, which includes new systems, new science, and new payment models. And everything that we've heard so far is spot on about the new systems and new payment models. And now I'm going to talk a little bit about the new science. I worked with Kenny Cole for several years at Blue Cross Blue Shield, Louisiana. He's the real deal. You can take what he says to the bank. And I'm an internist who worked in a small town where half the people died of cardiovascular disease. I was medical director of the ICU for 8 years and faced way too many people with really bad news. And then in 1995, we learned that medical treatment alone is as good as a stent with medical treatment. And the first trial that proved that came out in 2008. So that's the Courage trial, and Dr. Bill Bowen was the lead investigator there. There have been 15 trials since to make the point that optimal medical therapy alone is just as good as optimal medical therapy plus a stent if you have stable angina. And Dr. Marone was the lead author in the ischemia trial, which proved the same thing in patients with more advanced disease. In Great Britain, optimal medical therapy done by primary care has been the way they've done business for at least 10 years now. And they live longer for half the impact on gross domestic product as healthcare has in the United States. In Singapore, they have teams to deliver it within advanced primary care systems, and their healthcare has 1/4 the impact on GDP that ours does. And so in other places, this is just the way things are done. And it's important to know that finally in our guidelines 2 years ago, optimal medical therapy for patients with stable heart disease became the new guideline in the Journal of the American College of Cardiology. And so exactly what is optimal medical therapy? It involves everything you've heard to this point, plus a comprehensive set of integrated evidence-based care processes consistent with best practices. So the studies I'm going to review in just a minute compare optimal medical therapy with usual care, which is the treatment we find in the broader community. Now, if you look at what a primary care doctor does in adult medicine, the first 3 diagnoses, hypertension, high cholesterol, and diabetes, are components of optimal medical therapy. So 3 things are in optimal medical therapy are goals. You get the hypertension, cholesterol, and diabetes to goal, and then you have to get people to stop smoking and take an aspirin if they're high risk. So there are only 5 things. And nationally, as John said, only about 20% of patients achieve it. But in Minnesota, they report on optimal medical achievement in 500 groups across the state, and they report it publicly. And so in one state at least, optimal medical therapy is part of what they do. So if you bring all the systems and the payment model and the new science together, Kaiser Permanente in Colorado delivered optimal medical therapy to 628 patients who had had a heart attack and compared it with patients who had had a heart attack in usual care. So within the same system, same building, same resources, but look at the astounding difference in cardiovascular mortality is 10 times as great. And I really want you to pay attention to this. All-cause mortality is at least as great. And we'll talk more about the reasons for that later. And you can see easily here as well that tens of thousands of dollars are saved by optimal medical therapy in these high-risk, high-cost patients that John Rodis talked about earlier. And if you apply the same methodology to diabetes, so these were high-risk diabetic patients, type 2 diabetic patients with chronic kidney disease. And just look at the difference in 21 years of follow-up. I didn't get this on the slide, but there's a 70% reduction in heart failure hospitalizations, a fifth as many heart attacks, a fifth as many strokes, a tenth as many stents, a sixth as many people progressing to dialysis. And for the first time that I know of, the optimal medical therapy patients lived 8 years longer, and their cardiovascular events were delayed by 8 years. And so you might ask, how are these very dramatic differences in clinical and financial outcomes possible? And the slide really explains it all. So this same central signaling in molecular biology and epigenetics, and I'm going to explain this in a way you can understand. What we can see here is that you have heard of vitamin C and vitamin E, taking those things to reduce oxidants, to reduce oxidative stress, improve your health, slow aging, and help you live longer. And all that's right, but everything in the red box increases oxidants, including increased abdominal weight and tobacco smoke. And then all the green box interventions are antioxidants that meet the promise of antioxidant therapy. So they meet the promise of antioxidant therapy, and they don't just lower the blood pressure and the cholesterol and the sugar, they interfere with the fundamental biology that causes the blood pressure and sugar to be high, but it also interferes with the biology that causes heart failure and chronic kidney disease and sudden death in cardiac patients. It also impacts aging, other chronic diseases, and cancer. It's all caused by the same molecular biology and signaling. Genes that are essential for the fetus to develop become quiet in healthy young adults, and then they're reactivated to produce more oxidant in patients with extra abdominal fat and patients who smoke. And that's how it all ties together.
Thank you so much, Bill. Thank you so much for explaining optical medical therapy to us. And I love how this all ties together. So thank you for doing a great job. And I want to thank all of our panelists for giving great presentations. And, and as I turned over to Jeff, I'm just, it's stunning when you see the figures about the degree of reduction in substantial things. And people lose perspective when you're talking about 80% reduction of strokes or heart disease or heart attacks or a third or less amputations. Seatbelts reduce mortality by 45%. Nobody thinks twice about that. Somehow we don't spend enough effort on this. So I'm going to pass it over now to Jeff Hogan, who's one of the founding members of the Moving to Value Alliance. Jeff has been fielding questions. Jeff, take it from here.
So on today's session, we have lots of employers. Bill and Ken, employers are now more than ever, they must have benefit plans that are attractive and useful to their members. In fact, the new Consolidated Appropriations Act requires that they prove to members and others that they're contracting with the right providers for services. Few employers know how to do this. Do you see advanced primary care with OMT inside as a great first step for employers, thereby creating accountability to members and potentially predictability for purchasers?
Yeah, I'll start and just say, yeah, absolutely. I mean, I think that one of the problems you get with broad networks of lots of providers that allow employers that they're members of their health plan to have this incredible variation of choice. One of the problems with that is you open up this problem of clinically unwarranted practice pattern variation, where you're really dependent upon the level of knowledge of disparate providers across a broad stretch that, not all of them are practicing the same way. And there's no sort of accountability for outcomes and results in terms of, and so the way to tie it all together is, advanced primary care, really the whole basis of it is about outcomes improvement, and then optimal medical therapy, and I'll let Bill address that, becomes an essential component of your outcomes improvement cycle of how you deliver a differentiated value proposition.
Thank you.
Yeah, so, what I'll tell you, like I said, I've worked with Kenny for a long time, and we've discussed this fairly regularly. And I can tell you, John mentioned the hypertension control rate in the country is 44%. When you bring to bear optimal medical therapy, and the systems and the finance model that Kenny's talked about, his hypertension control rate's 90%. 90%. Well, Kaiser Permanente, Northern California, 750,000 patients, 90% hypertension control rate. So, I mean, all this stuff can be done. They're doing a damn good job of it in Singapore and Great Britain. And we're stuck in this crazy upside down model, this upside down system. And we're all paying the price. And the Institute of Medicine, National Academy of Medicine, 21 years ago, recommended that we make these changes. There are primary care doctors focused on people with special needs. There are urgent care centers. There are hospitalists. But there are no teams, or very few teams, in the country that are focused on chronic disease. And you just saw that's where all the money is. It's really kind of crazy. And then the people, well, I'll just say one more thing. I have seen data in the recent literature that if you get this right as a Fortune 500 company, you can add 3 to 4% to your profit line. And in today's environment, I don't know many places where you can do that. So I'm just shocked that it's taken us this long to get going on something that seems so obvious.
So 30 second follow-up, Ken, to that specifically. Is there a way to discover, again, for employers wanting to get advanced primary care that they attribute to their populations, organizations like yours that actually use this therapy inside, like a Intel inside marketing piece? I'm deadly honest about the question.
Yeah, I mean, I think that the biggest barrier to someone like, both Bill and I trying to do this is the economic model, that if it's a transaction-based fee-for-service volume-driven economic model with no accountability for outcomes or total cost of care, you're going to get what you've been getting for the last several decades. And so the only way to change it is to align the economic model with the outcomes that you're expecting to get from the employer side.
And that's not easy to do for employers. This is a tough one for them to approach. So next question is for everyone, and I'm going to ask you to keep your answers tight. It's a really good question. That the biggest problem is accessibility of cost and outcomes information in a consumable manner. 32BJ was able to leverage this sort of insight, but it wasn't easy, and their tool set isn't available ubiquitously to other fiduciaries. Any ideas from this group on how to democratize access to such a tool set to make these solutions more obvious, applicable, usable for employers?
Well, I'll take a shot at that. That's what I've been working with Justin Davis at Congruity Health for since April a year ago. And you can go to the TPA and get claims data and digest that and really do a good job with reducing cost of care. And part of the huge problem is that this data is opaque, it's hidden. The people who are winning now don't want you to see it. And our commitment is to be completely transparent with the data that we collect. And then on the clinical side, at baseline, your best quality measure is optimal medical therapy achievement. How many patients have their pressure, sugar, and cholesterol controlled to goal off cigarettes and taking an aspirin? And if you achieve that with the right medicines that protect organs and cells, you just get these dramatically different results. And so we get that baseline data and we report back quarterly. Okay, your pressure and cholesterol levels are great. Let's get your sugar under better control. So that's the way that system works.
Fair enough. So change up the questions a bit. Dr. Rodis, lifestyle medicine is intuitively sound, smart, and practical. Do employers have a role in bringing lifestyle medicine programs to their members? If so, how do you envision that happening?
A few years ago, I chaired the American Heart Association annual meeting, and I offered up to the audience, and I'll offer it to this audience. I'll come into anybody's company if you have a meeting with your employees and have this discussion about how they can help change their behavior. I think as an employer, Jeff, I felt actually a moral imperative to try to do the best for my employees. Unlike your health plans that change every year or two, or your brokers that may change every few years, my employees at St. Francis work for 20, 30, 40, and I had some employees 50 years. So who has their health in mind more than me? I spend money to hire them, recruit them, retain them, and I pay all their costs. So I think I felt a moral imperative. So I'll give you an example of what practically, when you start thinking of it that way, I'd go to the cafeteria and I'd see a slice of pizza that had about 800 calories, a lot of saturated fat, processed meat in it. And I said to my manager of the food services, why don't we just give our employees cigarettes? And, and I was obviously tongue-in-cheek saying that, but I worked with Sodexo at that time to change the menu we had for our own employees, to move the high fructose corn syrup beverages to a less convenient location, to put water more prominently, to offer healthier meals for breakfast and lunch. A lot of my lower paid employees actually eat 2 meals a day in the hospital. So I put a nutritionist at the end of the food line at the salad bar. So when people were making salad, supposedly healthy lunch, and then they're about to put a dollop of blue cheese dressing on it, the dietitian would say, if you just use a little olive oil and vinegar, you really would help. So I think there's a lot you can do, especially around food within your enterprise. But honestly, I think it's about educating, especially that 20 to 50-year-olds who often don't even have a doctor. It's about educating them about the things that I've talked about. And like I said, I offer this to this audience. I will come speak to any group. I've done this before, and almost every time, some people in that audience change their behavior. You know what? If I affect one person who doesn't end up with diabetes and hypertension and amputation and dialysis, I think I've done a good job.
Great, that's helpful. So this session occurs in the state with the lowest commercial investment in primary care in the country. What experience have any of you had persuading employers and policymakers, two completely different groups, that advanced primary care is a critical investment that produces ROI?
So I'll go. I did have some success in a previous role where, we did it. So first, we proved the concept first for members of our own employee health plan, and basically generated significant savings for ourselves that we were then able to, open up to another very large, self-insured employer. That previous role was a smaller system, and so the idea is how do we make this much more available on a broader scale. Which is why I'm where I am currently. And the organization I'm at currently, we have over 35,000 members of our self-insured plan. So we're the largest employer in our state. And so right now, I'm at the point of doing this for ourselves internally, but the hope is we can also do this for others.
Excellent. So next one is primary care physicians work insane hours. What is, and Kenny, I think you got into this a little bit. And by the way, Bill, I would love to hear you talk about nurses here and what you've done with that. What is the most efficient way to train existing providers? So the question was physicians, and I'm putting in providers about OMP. How does one advocate for this in med school curricula? And how does it get embedded in standard of care protocols, which may also include interoperability and EMR? So there's a whole bunch of questions there. I hope somebody grabs one of them.
It's going to be decades in the making to get ultimately where we really want to get. I think right now the training of physicians is you begin in definitive models where, a lot of this is sort of like creating this minimally viable product where you're really, honing all of the concepts and the variables and everything that you need But once you thoroughly understand all of those variables, now you can replicate it, you can scale it. So scalability just becomes a function of both the ability to show profitable growth and then the replicability. I think like with medical, schools, I think, I know I give a talk every year or two, to the medical students where I talk about these types of things. And ultimately, I just think it's going to be a matter of diffusion. And it's what I think will accelerate it the most is when we really get to a point where we are measuring outcomes reliably and have performance transparency on those outcomes rather than performance transparency on prices. Because, it's prices is just one function. What the other function of total cost of care is utilization. And what we're talking about here is driving down avoidable utilization to drive down total cost of care. It's not a price discussion. It's really going to be transparency around outcomes.
And Bill, before you answer, just real quick, just a follow up there to that comment. You talked about obviously teams, integrated practice units. The assumption is that these protocols have to be taught to all of the members of the integrated practice unit. Is that correct?
Well, an advanced primary care medical home, an advanced primary care team within a practice. In Singapore, they have these comprehensive primary care sites, one-stop shops, and within those shops, they have hypertension, diabetes, and lipid teams. They call it cholesterol. So they focus on those three most common causes of a visit to primary care. And with that focus and using the protocols and the design that Kenny talks about, they just do a stellar job. And one of the things that's occurred to me is the biggest barrier to everything is the payment model. As long as we don't pay for value, we're not going to make any progress. As long as it's not a better life for the primary care doctor, I'm not going to get him off the hamster wheel to listen to me about something that doesn't matter to him. But this is so important. There's an article from Diabetes Care about how we fail our patients with type 2 diabetes. That's the article. And the premise of the article is, everybody knows we need to get those 5 things done to deliver optimal medical therapy. It's only happening in a minority of people, we all don't even get all the hypertensives to the goal, half the hypertensives. We surely only get a minority on optimal medical therapy. And there are all kinds of things that make sense. So reminders, embedded suggestions in the EHR, reminders to the patient, sending a note to the primary care provider with a suggestion about what the change in treatment should be. The only thing that worked is developing the kind of teams, focused teams that Kenny talks about and has developed, and having them able to having nurse practitioners and PharmDs empowered to make changes to treatment in real time without checking with the doctor, because the doctor's on a hamster wheel. So if they have to check with the doctor, they're just not going to get there. And I think it's also important to realize that all the states in your region, New England and New York, the nurse practitioners can practice independently. Definitely over the half the states. I think it's 36 states. Nurse practitioners can practice independently, but they're in the same shape as primary care doctors. Hell, they can't practice independently because the financial model doesn't allow it. So, we're right on the cusp of being able to really improve health for most people and lower costs dramatically. But we just got to make the turn. We got to start. We got to roll up our sleeves and begin. There's nobody on here young enough that we won't be changing this as long as we're all alive. It's highly iterative, but we can do better than we're doing today in 6 months. And that's what we need to do. We need to roll up our sleeves and start.
That's great. So last question is for Dr. Rodis. Thanks for your comments on menus. I've heard many of the issues of individuals with allergies being offered food with allergens went inpatients in the hospital? Are there any universal standards of hospital care to ensure safe food options for those populations? And that's going to be the last question.
Yeah, I just read an article that Sodexo had posted actually on LinkedIn at one of the hospitals they work with in New York. 50% of the patients in the hospital are choosing the plant-based healthy options. So part of it is having these on the menu, educating the patients, because at least patients in the hospital, if you think about it, are an incredibly captive audience, right? They're already sick and they're in the hospital and they probably don't want to be there again, regardless of how good we take care of them. So it's now I think it's a little late, but it's still better than not getting to them at all. So yeah, I think you can do more. I love Bill's closing comments there. I think we all can do more. We can all do better. Has to start earlier. We have an obesity epidemic in adolescents now. So this all has to start in school. I think there's probably got to be a public policy component. We have to teach folks about behavioral change. Medical schools have to change the curriculum. But Bill hit it on the head. You can start making a financial better impact very, very quickly with doing some of the things he was talking about. And the things that Kenny and Gary talked about will have a very short timeline of return, but over time will have a tremendous impact. Again, Jeff, thank you for moderating the questions. I want to thank our panelists. Thanks to the audience. Appreciate it. Again, you'll have access to the slides and the audio presentation. Please join the Moving to Value Alliance. And I want to thank everyone. And thanks, Karen, for managing our technology today. So thank you all. Have a good afternoon. Have a good weekend.
Thank you.
Thank you.
Thank you.
You might ask, how are these